Good morning, everyone. For the next segment, I'll be taking over as your moderator. We are pivoting now from ENT to ophthalmology to look at global ocular health concern that is growing rapidly. Our next topic for today, managing childhood myopia beyond spectacles. To walk us through this vital topic, it is my absolute pleasure to introduce our next speaker and my good friend, Dr. Irina Effendi-Tenang. Dr. Irina is a pediatric ophthalmologist at UMMC with special interest in childhood myopia and myopia control. She's a part of the ATOM Malaysia team in PPUM and actively involved in clinical care, teaching, and research in pediatric eye health. So, Dr. Irina, the visual floor is yours.
Good morning, everyone. Thank you very much, Najieha, for the very kind introduction. I'm Irina. I'm one of the pediatric ophthalmologists in UMMC, and this morning I'm going to be talking about childhood myopia or nearsightedness. Oops, how do I move this slide? Right. So what is myopia? Myopia is being nearsighted, and it is, in short, the inability to see objects clearly at a distance. If you look at the diagram on your right, on the left is that of a normal eye, where the focal point hits the retina nicely. And on the far right is an elongated eyeball, or a myopic eye, where the focal point falls in front of the retina, hence the image seen is not clear. So myopia is when the eyeball is too big or too long, causing the focal point to fall in front of the retina, or the focusing power is too high, again, causing the focal point to fall in front of the retina. So not an issue. A lot of people wear glasses. Our two moderators are known to be myopics. So you just correct this with glasses or contact lenses. So how do you know if your child is myopic? So it's a bit difficult to tell because it's difficulty in seeing something far away. So most children don't realize that they are myopic. What often happens is when they start going to school, they are being sat at the back or in the middle of the class and they can't see the whiteboard. So that's when the teachers flag up that your child has difficulty seeing the whiteboard or the blackboard. They've been asked to sit in front. So these are the few clues to tell you that you should get your child checked at an optician. Other signs would involve squinting, like this young boy over here. Eye strain, especially after prolonged visual task. They often complain of headaches, often due to eye fatigue. And these kids tend to sit really close to the television or bring their handphones or iPads or gadgets really close to their face. And they also have frequent blinking or rubbing of eyes, particularly in pre-verbal children. So I'm just bringing you back to optics and your days in physics. The top picture is that of someone who is myopic or nearsighted. So you see again, the focal point falls in front of the retina. So how do we correct it? If you ask all my myopic friends, they wear spectacles, and these are often concave lens annotated with a minus sign. So just to illustrate to you, the more minus your lens is, the longer your eyeball, or the longer your eyeball, the more minus your lens, the more minus a lens is required to correct your refractive error. And just to compare with those of farsightedness, it's the other way around. They are given a plus lens to get the focal point onto the retina. So what is the big deal? Half the world population wear glasses. If you look left and right, a lot of us wear glasses. Not an issue, just put your glasses on and you're fine. Now, the big deal is myopes, especially high myopes, which means their eyeball are much longer, especially those where spectacle powers are -6 and above, they are at higher risk of eye complications. And the most pronounced one would be retinal detachment. They are also at high risk of getting cataracts, myopic macular degeneration, and glaucoma. And the way I always explain this to some of my patients is that you imagine that the eyeball is a room and the retina is the wallpaper. So when the eyeball or the room is elongated, your wallpaper gets stretched out over a larger area. And this wallpaper of yours is a nerve, it's the retina. And when a wallpaper gets stretched out, it becomes thin and it is more prone to having holes, which also makes it more prone to being detached. So this wallpaper of yours can easily get peeled off by the wall of your eye. In short, a retinal detachment can occur and is in higher risk of those who are higher myope. So the higher your myopic power is, the higher your risk of retinal detachment. And there are studies that look at this risk. And you can see that just from being a -1 to -3, you are 3 times risk of getting an RD, a retinal detachment. If you look at -5 to -7, you are at 21 times more risk of having retinal detachment. So our main aim is to create awareness about myopia and how we aim to control it, especially in childhood, as the eyeball is still growing. And we've noticed increasingly that there is an increasing numbers of myopia, especially in younger children. It does pose an economic burden to society. You do need, people with myopia will need glasses, contact lenses, or refractive surgery to get that focal point onto their retina and to be able to see clearly. And of course, there is a healthcare burden in terms of treating sight-threatening myopia-related complications like retinal detachments and cataracts. So there is an increase in myopia. In 2010, the WHO reported that more than a quarter of the global populations are myope. And it's projected that by 2050, that's about 24 years to go, half the world's population will be myopic. And it's mainly due to our lifestyle currently. Let's look at some local data. Just in our neighborhood, Gombak district found that the myopia prevalence increases with age, with about 10% at age 7 and more than a third at age 15. And we also noted, and this is an urban, Gombak is within Klang Valley, more than 50% of children need glasses but are not wearing them. So who gets myopia or who are at higher risk of being myopes? Parental myopia is where 1 or 2 parents are myopic, so you can pass it down to your kids. Even if your partner is non-myopic, you being myopic alone does increase the risk of your kids being myopic. And number 2 is education. School length and intensity plays an important role in increasing the risk of myopia in children, especially in urban population and in towns, where education is highly emphasized upon and gadgets are being used. It's mainly to do with near work, and this increases the risk of myopia in our kids. Time outdoors is a protective risk factor against myopia. If kids do not spend enough time outdoors, i.e. they spend a lot of time indoors doing a lot of near work, they are at high risk of being myopic. And another important predictor is the age of onset. The earlier a child is myopic, the risk of progressing into a higher myope also increases. So I'm just looking a bit closer to risk factors of myopia. This includes near work. So now everyone has a gadget with smart devices, computer use. This all increases the risk of myopia. In fact, the American Academy of Pediatrics have recommended that children below the age of 2 years old have 0 screen time, and they are only allowed screen time to do video calls with family members. And children up to the age of 5 are allowed a maximum of just 1 hour of education programming via screens. And I know this is not the easiest to do, as I've got a 4-year-old myself who is, if allowed to, will be attached to screens and phones. Looking at parental myopia, there are several studies. There's a big study 2020 looking at more than 9,000 children in US, Singapore, and Australia. And you've got 1 parent with myopia, your odds ratio of passing it down to your kids is 1.42%. 2 parents is 2.7 times. 2 parents with childhood onset myopia, the odds ratio increases to 3.39 times. And a Hong Kong study in 2020 shows that if you've got 2 parents who are myopic, you're 11 times more likely to be myopic. So again, looking at some other studies, you have young age of myopia at onset, you're at higher risk of, you are associated with higher myopia. And if you are a myope at age 6 to 7 years old, 50% will develop high myopia. Just going back to myopia risk factors, so age of onset, you don't want them to be myopic at a very young age. You've got a myopic parent. If you're spending less time outdoors, you're doing lots of near work, these are all risk factors for myopia. The other thing I would like to add is prematurity is also a risk factor for myopia. So all our prem babies, especially prem babies who has got retinopathy of prematurity, that increases your myopia risk as well. So what are ways to treat myopia or ways to clear the vision? So majority of ways would be spectacles to get that focal point onto the retina. Non-spectacle options involve contact lenses, which may not be ideal for children. Surgical, which are refractive surgeries such as your LASIK, your SMILE, but again, not suitable for children. Is there a cure for myopia? No, you can't shorten the eyeball again. Can we slow the progression of myopia? Of course, the aim is to halt myopia. So there are several ways to do that. And number one is lifestyle changes. So get your kids to run outside, spend a lot of time outdoors. What we want is to relax the eye and get them to see something 6 meters away. This may not be ideal, as most of our houses, especially if you're watching TV, it's still 3 meters away, unless you've got a really big bungalow where you've got 6 meters worth of space. And it's also important that it's the outdoor light that is protective against myopia. So going out to the shopping mall doesn't count. And of course, you reduce near work. Of course, we want children to be reading, to be doing their homework. That's all well and good, but screen time should be reduced to only ones that are required by the school. That takes up about your 1 to 2 hour quota per day already. Other intervention, if lifestyle can't help or doesn't help, would be medication, which is our eye drops. It's atropine 0.01%. We've also got atropine 0.025%. Other ways to slow or halt progression includes non-medication ways, such as your defocusing glasses and your ortho gauge, contact lenses. So there are several ways to help halt or slow progression of myopia. So I like to emphasize on lifestyle modification because this is something that every child should be doing. You have to spend at least 2 hours a day outdoors. I understand this may not be ideal, especially if you've got very busy parents who come home, it's already late at night. Safety is also an issue in our country. And if it's not time and safety, it's the weather. It's either raining cats and dogs with thunder, or it's really hot and jerebu. But what I tell parents is try to get them outside. If you're over the weekend, if you're cleaning your car, hanging your clothes, get your kids out with you. This may not be ideal. Some of them tell me they're staying in apartments, you can't get them to their balcony. So bring them out to the park over weekends. Every little bit helps. Get your kids involved in sports, especially outdoor sports. If they're playing football, archery is great because that's a solid 15 meters or 30 meters away. But all has to be outdoors and not indoor sports. Okay. Also practice the 20-20 rule. Every 20 minutes, take a break for 20 seconds and look at something 20 feet away. Practice good hygiene when reading. So there's an elbow rule where you keep a forearm distance between eyes and the book. Screen time should be less than 2 hours. And in this day and age, every child I speak to, every parent I speak to, the school homework via Google Classroom. They have tuition class online now. So that takes up most of the 2 hours already. Those who are on glasses, full-time wear matters. A lot of parents are very hesitant to put their kids on glasses because they think that if you put them on glasses, they'll be dependent on glasses. So you have to explain to them that wearing glasses brings that focal point to the retina. So your child needs that. It needs glasses to be able to see clearly. Now, children who are undergoing treatment to halt the progression of myopia, such as using atropine, they will still need glasses to see clearly, right? So this is important to understand. Because some people say, right, just put atropine in, we don't need glasses. No, you still need glasses to correct the myopia, to correct the refractive error. The atropine is there to help slow down or halt progression of myopia. Okay. I always share this slide to show that outdoor play works. So this is from 2022. It's a primary school in China. And if you look at our Oriental counterparts, China, Singapore, Hong Kong, we are very gung-ho on education, which is good. There's a lot of near works in their children. So there's a lot of incidents of myopia, especially in these countries. But this particular school scheduled in a solid 3 hours of outdoor games every day and the 10.5 hours of sleep. And all of its 536 students cleared the myopia test. The most effective of all these measures is the 3 hours of outdoor games every day. So this may not be, realistically, it's a bit difficult for us to implement it, but what we are doing is trying to create awareness, so that schools are also involved and they know the importance of getting these kids outdoors. Of course, safely with sun protection and weather protection. So if you suspect your child is myopic, what I would recommend doing is go to any optical shop and get their eye spectacle power checked. Who should be seen by an ophthalmologist? Any child less than 6 years old with any level of myopia. Because any level of myopia below 6 or 7 is known to have a higher risk of progressing into high myope later on. Any spectacle power of more than -6, that's a high myope already. Frequent changes in spectacle power. So this shows that the myopia is increasing and the eyeball is still growing. Anisometropia is where you've got a difference in power in both eyes, and if they've got a squint or an eye turn. Of course, get them on glasses. I always tell parents it's not the easiest to get glasses onto patients, and that's perfectly normal, especially children. So you do have to persevere, especially with the first few weeks. But once the child gets used to it, and once they know that they can see clearer with their glasses, most of them do really well. And of course, follow up with an optical shop. So among the medication that we use to slow down or halt the progression of myopia is a very low dose atropine of 0.01%. It is used once at night to slow down worsening of myopia. And it slows eye growth, it prevents the power from increasing too fast, and studies have shown that it reduces myopia progression by up to 60%. Who can use it? Children ages 6 years and older with progressive myopia. And it's safe to use long-term with regular eye doctor checkups. So they must be seen by an ophthalmologist. Children generally don't feel anything. Sometimes they do get a mild blur, near vision or light sensitivity, but this is rare, which is why we do give them a check 6 to 8 weeks after initiating the eye drops. And how is it used? It's used 1 drop each night before bedtime. And you press gently over the tear duct to prevent it from draining and to reduce the systemic absorption of the drug into our body. So currently in PPUM, myself and Prof. Liza are doing a study on myopia 0.025% for progressive myopia. So if anyone's interested to know more about the study, you can send me an email and we can have a quick chat. Future directions, public health strategies. We are doing school screening programs to primary schools within Klang Valley. We've been going to a couple of schools over the past year to check visual acuity and refractive error among school children. We also give talks to parents and teachers to help create awareness. And it also helps teachers to be more aware of myopia and more mindful of more mindful of the activities that the kids do at school. I think I've come to the end of my talk. Thank you so much for your time. If there's any questions, there's some in the chat box. I think.
Thank you so much, Dr. Irina, for the insightful presentation. Yeah, so we will now open the floor for any Q&A session. Let me have a look. All right, so there's one question to you, Dr. Irina. How long does a child need to use atropine?
Right, thank you very much. It's a very important question. So studies have shown that if a child starts atropine, he or she needs to be on it for at least 2 years, because there is a rebound effect if the atropine is stopped prematurely, right? So a minimum of 2 years. So before I start, I have a proper sit down with the parents to make sure that both parents and child are on board. The other important thing to note is most children will be on atropine till early teenagehood, because we know that that's around the age where the eyeball sort of stabilizes and stops growing. So stopping doesn't mean stopping abruptly either. We normally stop from, say, you're putting in 0.01% once at night. We go to alternate days or twice a week for 6 months and see if your axial length and your power stabilizes. And if it does, you reduce it down to once a week and then you take it off. So it is something that you will be using long term, but with close monitoring with an ophthalmologist. I hope that answers your question.
So we have another question. If both parents are high myope,
Mhm.
is there any rule of prophylaxis myopia before the child develop myopia?
There is a rule. We are working on the clinical practice guideline at the moment. Off the top of my head, I can't quote any studies, but there is a rule for prophylaxis, where if you think at age 6 or 7, 6 or 7, your child is say -1, that's already myopia. So if you're a high risk, yes, there is a role of prophylactic myopia. If you think about it, at age 4 or 5, the child should be emmetropic. Below 4, a child should actually be a plus because the eye is still growing. So if at less than 4 years old, your child is already a minus, you've got to monitor closely, and then you can consider prophylaxis, say about 6 years old. That's where myopin is approved. We have used myopin in 4-year-olds before, but of course with close monitoring and parents are on board and knowing the side effects of atropine.
Okay, so we have another question. Why is the cost of myopin eye drop?
Right. So in PPM, we've just brought it in, I think, early this year. Thank you to the pharmacy team. And it costs, if I'm not mistaken, about 70 to 80 ringgit per bottle. In UMSC, I think it's about the same. You can get, say, 0.025 would have to be mixed. So there's another supplier in Cyberjaya which does that, including postage and whatnot. It can cost up to 100. So you're looking at about 75 to 100 ringgit per bottle per month.
All right, so we have another question. Why is the cost of myopin versus myopia glasses in the long term?
Right. So myopia glasses are a bit more expensive. There are several brands out there. I think there are 3 main brands, and off the top of my head, the price can be in you're looking at 4 digits, 1,000. Our Lux Vision just down the road has got all 3 brands. I think they're having an offer on one of the brands. I don't have any financial interest, but the idea is if you are on the myopin glasses and you halt the progression, you then save costs on the frequent change of spectacles. Of course, then there's the eye drops as well. So it's a bit difficult to say which is more cost effective. I would say which one works for your child, really. Some kids do well on atropine alone. Some kids do well on myopin glasses alone. Some kids need both. So I would say do either one. Of course, both has its pros and cons. With eye drops, you're looking at putting eye drops into a child. So some children just can't do eye drops. They just can't do eye drops. So you don't have a choice but to go down the other route. And some families go like, look, the glasses are a bit too expensive. We can't put in that amount of money. So yes, let's go with the eye drops. So it's a lot of factors to take into account. It's the child's compliance to medication, or eye drops per se, or glasses. Is the family situation financially, and it's also the how the child responds to the progress, as well as lifestyle modifications. Because don't forget that the number one thing to do before doing all of this is your lifestyle modification. I hope that answers your question.
All right, I have one more question. Is there any side effect of the atropine eye drops that parents should be aware of?
Right. So atropine eye drops are very low dose atropine, so 0.01%. It can cause blurring of vision and glare, which is the most common. We look at pupil diameter before we start atropine. It can cause flushing and tummy ache. So these are some things that some children just can't stand. So these are the few things that we tell parents to look out for. So when we start off atropine, we normally see them at about 6 to 8 weeks to see how they are doing and whether we should continue with atropine, whether it's suitable for them. So these are some few things that we tell parents to look out for.
All right, okay. All right, thank you so much. We have had an incredible session today with 2 our outstanding speakers. I want to extend our deepest gratitude to both Dr. Gagandi from ENT and also Dr. Irina from Optal for sharing their time and expertise with us today. To everyone online, thank you for joining us and have a wonderful and productive week ahead. I think we shall stop our session today. Thank you so much.
Thank you, Najieha.